Welcome to a CME podcast episode from NEI, the Neuroscience Education Institute, hosted by Dr. Andrew Cutler. For complete CME information, please refer to this podcast's description page or go to nei.global/podcast.
Hello and welcome to another NEI podcast. Today, I'm really excited to be talking about a very important clinical situation that we have a real expert to talk to us about, Dr. Phillip Coffin, who is a triple-boarded, board-certified in internal medicine, infectious disease, and addictionology. And he is in San Francisco at the San Francisco Department of Public Health and is also on the faculty at UCSF. Phillip, welcome.
Thank you, Andy. Pleasure to be here.
And we're going to be talking today specifically, I know you work in the field of addictionology a little more broadly, but we're going to be focusing on stimulant abuse, particularly methamphetamine. And there have been some recent developments. Of course, it's a huge clinical need. So why don't we just get started and kind of lay the landscape and talk a little bit about what's happened with stimulant use, especially methamphetamine and cocaine in the past few years.
Sure. So stimulant use has overall increased in the past 10 to 15 years, particularly probably methamphetamine. Cocaine use, we've seen increase in the context of fentanyl use. So there's kind of two different types of use that we're thinking about today. One is use with opioids, and the other is use in the absence of opioids. And I think of sort of pure stimulant use as kind of in the absence of opioids. And that we've seen cocaine be sort of stable to maybe decrease a little bit, and methamphetamine increase maybe 50% or so. In the context of with opioids, we've seen a lot more increase because of the sedating nature of fentanyl. You see a lot more stimulant use paired with fentanyl use to help mitigate the sedating nature of it. And according to some people and some studies, actually kind of raise the threshold to respiratory depression from fentanyl. Some people think it helps them to avoid an overdose, which while that is true in some pharmacologic circumstances, when you actually see the use together, it leads to people pushing higher doses of fentanyl and more chaotic use patterns, and you actually end up epidemiologically with more overdose rather than less, unfortunately.
Yeah, that is. Yeah, it's true. We don't hear as much about cocaine. We do hear a lot about methamphetamine and amphetamine use in general. But boy, fentanyl we keep hearing about. And I was surprised to hear that there's a significant percentage of methamphetamine users whose urine is also positive for fentanyl. So you're confirming that. It sounds like people are doing this maybe on purpose.
Most of the co-use is intentional and probably primary fentanyl use. There is methamphetamine and cocaine put into fentanyl to, again, mitigate the sedating effects. There is also unintentional fentanyl use among people intending to use stimulants. This usually occurs through either using the wrong implement, like using their friend's pipe and their friend had used it for fentanyl, or picking up the wrong drug, thinking that this white powder must be a stimulant because all opioids are black tar, and it turns out the white powder is fentanyl, and the overdose occurs rapidly.
Well, of course, as we know, fentanyl is extremely potent, much more potent than other opioids, so they're really playing with fire here. As I go around the country, it's interesting. There are definitely pockets, it seems like, of even higher methamphetamine, and I even have been to some places where they sort of brag. We have a lot of meth labs here. We're like the meth lab capital, so unfortunately, it must be fairly easy and cheap to make it. Is that true?
Yeah, it is easy and cheap to make methamphetamine. It's also not super tricky to make fentanyl, which is part of the challenge of addressing the evolving crises.
Yeah, I didn't know that either. Okay. Now, I've always, substance abusers, in my experience, which is not as extensive as yours, are really pretty good amateur psychopharmacologists, I find. They really know how to mix and match and do one to bring them up, another to bring them down. So it sounds like that's a little bit what you're talking about here. Of course, my bias, too, is there's a lot of self-medication, if you will. So how often does stimulant use disorders co-occur with other psychiatric diagnoses?
Frequently. I'd say the most you see, well, of course, you always see lots of post-traumatic stress disorder, bipolar disorder, anxiety, depression, that those are going to be highly prevalent. And you also see, particularly I'd say with methamphetamine, a lot of attention deficit disorder and the earlier than would otherwise be emergence of psychotic disorders.
Interesting. Well, yeah, I mean, certainly we can precipitate. And I was going to ask about ADHD. So, it's really interesting. We prescribe amphetamines for ADHD, and yet, of course, methamphetamine is so much more potent and so much more likely to be abused. Is there a neurobiology to stimulant use disorder? Can you help us with the neurobiology and why does that make treatment so challenging?
I will, in full candor, say I don't spend my time in a lab focusing on the neurobiology. I focus more on the empiric treatments and strategies to assist people. Harkening back to my undergraduate days of neuroscience, it is, it's what we see with stimulants, of course, is a lot of dopaminergic activity and, in fact, some burnout of dopamine neurons in early onset Parkinson's disease. We also see a lot of activity of the adrenergic system and serotonergic systems. So when we try to develop therapies to help people reduce stimulant use, particularly methamphetamine use, we're really thinking about multiple neurotransmitters systems at the same time. So, some of our best studied treatments are mirtazapine, which hits 3 transmitter systems simultaneously, and the combination of bupropion and naltrexone, which again hits multiple neurotransmitter systems simultaneously.
Yeah. Yeah, I mean, certainly we're talking about a dysregulation of the motivation reward system, which is highly innervated by both dopamine and the endogenous opioid system. But you said something interesting there. You mentioned serotonin. And some people in our audience may not realize that amphetamines also increase serotonin release, and there's actually a warning in the label of prescription amphetamines for serotonin syndrome. So people may not realize that you are modulating these multiple neurotransmitters. It's really fascinating. And as a matter of fact, fun trivia fact, the first medication FDA approved to treat depression in the United States in 1939 was amphetamine. It was racemic benzodrine. Before we had monoamine oxidase inhibitors and tricyclics. So there's a long history of them being used, to treat depression and so on. Now, when I trained, I did a rotation in substance use. And when I trained, there was this really strange dictum that you had to have a person declare sobriety for a certain period of time before you gave them any psychotropic medication. And I certainly hope that that has been debunked and that's not the standard of care anymore. Am I right?
Absolutely. We've really moved on from this idea, which, as an internist is kind of the equivalent to saying you have to stop eating sugar before I'll treat your diabetes.
Exactly. Well said. But of course, there are, as we said, often co-occurring psychiatric conditions, and I can imagine that complicates things as well. When you're thinking about how you're going to help somebody with, of course, the use disorder, but also maybe treat the co-occurring psychiatric conditions.
It does get tricky sometimes. With ADHD, there's always controversy about whether, I think some providers feel that if somebody uses methamphetamine, they won't treat the ADHD with amphetamine type stimulants. And we've all seen people, once those amphetamine type stimulants are removed, we've seen people decompensate rapidly and end up in terrible crises with their methamphetamine use and out of control ADHD. We've seen, and in contrast, I have seen many providers who closely develop treatment plans using amphetamine type stimulants for people with ADHD and comorbid methamphetamine use with a lot of success, with close tracking and a lot of success. With the psychotic disorders, that can get a little bit tricky, especially for non-psychiatrists. As an internist, I'm a little more cautious with my psychiatric medications. I'm a little less willing to throw some of the serotonergic agents at somebody with a psychosis or a bipolar diagnosis. In contrast, my psychiatric colleagues feel much more comfortable doing that and combining medications and being more aggressive with some of these agents.
Yeah, certainly what would be appropriate there would be atypical antipsychotics, of course. Just a quick word about what you said earlier there. A good friend of mine, do you know the name Tim Willens by any chance? Tim Willens is at Mass General. He's kind of an ADHD guy, but he also specializes in substance use. And he has written about treating ADHD patients who are treated for their stimulant use disorder and treating them with stimulants appropriately for their ADHD. And as you said, they often do quite well. Does that name ring a bell at all? Maybe not. But.
It doesn't, but the story does. I've heard that in many circumstances, and I've seen patients that really thrive, and then I've seen the opposite when their agents are withdrawn.
Well, if you don't mind, I might arrange an introduction because I think you two would have a lot of interesting things to talk about and share your findings.
Excellent.
Moving on, of course, bipolar disorder, we also use atypical antipsychotics as well as other kinds of mood stabilizers. And of course, there's pharmacodynamic challenges, but also there can be pharmacokinetic challenges. As we know, these things interact with each other. And one other pharmacokinetic issue that I want to just ask your thoughts on, there's a lot of concomitant cannabis use, I would think, as well. And cannabis has been found to have some pharmacokinetic interactions. It interferes with some of the liver enzymes. So do you take that into account as well at all?
I haven't found that to be particularly relevant at this point in time. Am I missing something? Probably. There's a lot going on, but it hasn't been a significant issue in my own practice and research experience.
Yeah, so far it appears they interfere at least with CYP3A4, and some of our psychiatric medicines are metabolized by 3A4, so you just use careful dosing and things like that.
Right.
Well, I want to get into some of the treatments and some of the evidence. I was really interested to hear you say mirtazapine. I hadn't realized there's a literature on mirtazapine for this. Can you tell me a little about that?
Sure. That's some of the work that we've done in my shop in San Francisco. We've tested mirtazapine in 2 phase 2 trials, and in both trials saw, something equivalent to about a third reduction in methamphetamine use. The first trial was over 3 months. The second one was 6 months of treatment and then followed for 3 months off of treatment with some persistence in the effect off of treatment. It is the challenges are that it's a daily medication, and we know that medication adherence is challenging for people who use methamphetamine. Daily medication adherence can be difficult, and if you have ways to support adherence, incentivize or video or whatever, that can definitely increase medication adherence in daily dosing. The other major drug, the other sort of best studied treatment out there is the combination of bupropion and naltrexone. I think you know about the ADAPT-2 trial. And
yeah, it was published in the New England Journal of Medicine, for crying out loud. That's a real legitimate journal.
Yeah, it's probably our largest trial of a successful therapeutic for methamphetamine use disorder. And it's kind of left me right now when I think about, I spend a lot of time trying to get primary care providers to address substance use disorders. And the 2 pathways that I think about for treating methamphetamine use disorder as a primary care provider are either bupropion plus or minus naltrexone or mirtazapine plus or minus naltrexone. And for cocaine, you basically just have bupropion plus or minus naltrexone. We don't have any data for mirtazapine.
Yeah, mirtazapine's fascinating. A couple of the symptoms that are particularly troublesome to our patients are insomnia and anxiety, and of course depression, I should add. Mirtazapine kind of treats all three in a way. It's helpful for all three. And I mean, I'm sure there's neurobiologic reasons it might work, but I wonder if it's helping them to feel a little better, if you will, or to address some of those things.
It's a good question. We did assess for any connection between sleep or depressive symptoms and reduced methamphetamine use, and we didn't see that in the trials. That's not to say it's not there, but in our, modest, the first trial was 60, the second was 120 people. So, mid-sized trials, we didn't see an association. But I agree with you, mechanistically, it kind of makes sense. And there are reasons I'd jump in one direction or the other. Somebody who takes methamphetamine in the morning to get up and get their stuff done, I would lean towards bupropion as the agent because it's activating, it's stimulating, it's kind of an agonist therapy in a sense. If they tend to use at night when they're out partying with friends, I might lean towards mirtazapine. Maybe they're going to go to sleep instead.
That's certainly evidence-based, and it makes perfect sense. I think that's how we choose a lot of our medicines, based on these kinds of clinical scenarios. In the studies with mirtazapine and the bupropion naltrexone combo, did there seem to be subgroups who benefited even more? Is there any kind of marker you found?
I always think there are subgroups that are going to benefit more and that we don't know enough about the diseases. Sometimes I make an analogy to cancer. We often think about cancer based on organ system, but we've come to learn that genetics might be a more powerful predictor of response to many therapies. And with substance use disorders, we think of it by the substance, and there are clearly differences between the substance use disorders that we address. But sometimes I wonder if some of the characteristics of the use disorder, and we could probably do this by looking at DSM-5 diagnostic criteria for similarities, some of the characteristics sometimes you might see a methamphetamine use disorder that looks more like that matches with alcohol use disorders, and that might be more responsive to naltrexone therapy. And I wonder if we are at, in the 1970s phase of cancer, of understanding cancer in our addiction conceptualization.
I think that's exactly right. It's very well said. I've said for a long time, in oncology, they have things like tumor markers to pick the ideal chemotherapy, if you will, to guide them. We just, in psychiatry and in treating the brain, we don't have those kind of things. And yet, as you say, we all know from treating patients, there are some who just seem to do much better with one therapy than another. And I think we have to use these things you're talking about, our clinical skills, and maybe using analogies and recognizing patterns to some degree.
It's also important, with addiction to kind of recognize where somebody's at in their addiction and what kind of resources that they have. Resources drives a lot of substance use disorders in the sense that, during COVID lockdown, many of us drank more than we should have. And many of us, frankly, during lockdown, probably would have qualified for a use disorder. And yet, when we got out of lockdown, we went back to the gym, went back to our lives, had the resources and the community to distract us and take us away from whatever unhealthy alcohol use patterns we had engaged in and resume some more healthy use patterns. If you don't have those resources, if you don't have the social connections, if you don't have, frankly, the money, then it's really hard to get out of those patterns and back into healthy use patterns. So somebody's economic status and well-being is, frankly, part of the predictive like their likelihood of getting through a use disorder and how hard it's going to be. And that's an important thing that we rarely talk about in medicine, really the impact of economics and income disparities in the country.
Sure. And the social network, I think that's extremely well said. I imagine that's a big part of the treatment, is teaching people healthier behaviors. I remember working with some patients who said, I've got my stinking drinking friends, and if I cut back on alcohol, those are my friends. I'll go hang out with them, and they're drinking, and then I relapse. So we have to teach them healthier social patterns, recreation, all kinds of skills like that.
Another division point we see with some substance use disorders is sort of the severity and disabling nature of the disorder. When somebody using methamphetamine has developed a profound and persistent psychotic disorder with their use, and they have heart failure, they might, and maybe they're unhoused, they might really not be able to stop using. And that individual, I kind of transition to thinking about it like my father's diabetes. He was never able to get his donut habit under control. His A1C never dropped below 11. And yet he outlived his dad by 15 years because of aspirin and statins and ACE inhibitors and good podiatric care and good cardiovascular care. So we can do a lot for people short of extinguishing their substance use that can give them more time and more quality of life.
Well, you bring up another very important issue that we don't always think about, and that's the medical complications, the comorbid medical conditions, not just psychiatric. And certainly there's a lot of medical consequences here. And so I think that's a very important part of this too, is developing a relationship with primary care, internal medicine specialists that can help with all of those things too.
I agree. That's really an exciting domain for me.
Mm-hmm. Mm-hmm. Something that has always been curious to me, that gets back to what you were saying before about subgroups, is a lot of us in our youth will experiment with various substances and we go, oh, that was fun. But we don't fall into abuse. And I think it's almost analogous to a lot of people smoke cigarettes, they don't all develop lung cancer. There must be genetic or other predispositions here that when these people use, something really is triggered and their brain goes, ooh, I want more of this,
It's yes, and there are some genetic things that contribute to this. But again, probably the most powerful predictor is economic well-being.
That is fascinating.
It is true. Of course, people with money and resources still develop substance use disorders, but there's a higher barrier, a much higher barrier to develop a use disorder when you have those resources. So the ever increasing income disparities we've seen in the United States, frankly, are a major driver for our addiction crisis.
Yeah.
And a little bit beyond my pay grade to address.
Of course, I was just going to say these are policy issues. And as we know, substance use disorder, the resources have not been devoted as they should for treatment. And that's a whole other discussion, I guess.
I think we've had a really exciting period over the last 10 years. The opioid crisis brought in a lot of really, really exciting developments. The addiction medicine fellowship programs that emerged all around the country. This, personally, as a physician, fellowship programs are one of the most powerful, probably the most powerful way to develop a field and turn it into something real. Seeing trainees go through and work out new strategies to manage complex diseases is really exciting and builds community. And those programs, for me, have been the most exciting development in addiction in my career.
That is wonderful to hear. And of course, as you've said, the awareness of this has really been raised. And I think a lot of people in primary care have really started to learn a little more about this and how to deal with this and so on. It's not just a psychiatry condition. We mentioned the ADAPT-2 trial. Maybe we could just delve into that a little bit. What did it teach us, and how can we think about it in clinical practice? Is it something that you think is enough evidence-based that we should implement this?
Sure. The study was of a combination of high-dose bupropion plus injectable naltrexone for people with significant methamphetamine use disorder and frequent use. And it proved that with medications in a phase 3 trial, we can reduce methamphetamine use. The differences weren't enormous. It's not a slam dunk, but we have to be used to that in addiction, just like we are in any other disease. You have to have a quiver of medications to help people because people differ and we don't always know what therapy is going to be right for which people. Some of the questions that remain with ADAPT-2 include if it was truly an effect of both drugs or was it an effect of a single drug. The bupropion was 450 milligrams, which is a higher dose than in any other trials, and it was incentivized. People were paid $5 a day to video record themselves taking the pill. And that got adherence up to almost 70% compared to every other trial of bupropion with these mixed findings that had adherence of 15 to 30%. So I have always wondered if this trial was really a trial of high-dose incentivized bupropion. The studies of naltrexone have been more mixed results. The two trials of injectable naltrexone were negative. Some of the studies of oral naltrexone showed a benefit. So in this case, I feel comfortable using bupropion with or without naltrexone. I will tend to add naltrexone. Sometimes I'll add oral naltrexone since they're already taking a daily pill. And it's cheaper, it's easier to access.
Yeah.
And people, I'll in particular, I'll tend to add it to either bupropion or mirtazapine in the context of somebody who relapses when they go out drinking. So I'll get somebody down to, once a week or every other week relapses whenever they go out drinking with friends. We'll add on oral naltrexone, which we have proven you can also use as needed. So take naltrexone on Friday if you're planning to go out drinking Friday night, and you only have one drink instead of 5. And so I'll use it kind of in that fashion if I can't get, or I don't think injectable is appropriate for that particular patient. The injectable naltrexone might have an added benefit these days in protecting somebody from unintentional fentanyl use, given how much fentanyl is out there. So it is conceivable that the ADAPT-2 regimen could not only reduce methamphetamine, but actually directly save lives.
Well, that certainly makes sense. I was going to ask you about the pharmacokinetics here because obviously an oral pill might be getting you a higher blood level to some degree than a long-acting injectable. The other thing I noticed about this trial was they gave the injections of naltrexone every 3 weeks as opposed to every 4 weeks, and that may also provide a little bit of better pharmacokinetics.
That's true. Yeah. There was concern that in that 4th week, you're really losing some of the benefits of that injectable agent. We see similar things with injectable buprenorphine. We see the effect really kind of wearing off more than we're comfortable with in that final week.
Yeah, I've certainly heard that. So I guess, as you're saying, this was really optimized treatment as far as dose and incentivization and adherence. So this really was optimal use of these treatments.
It's hard to do this well in real world practice.
Yeah. Now, I know I'm going a little off topic. I want to ask you real quickly. There is another medicine on the market called solriamfetol. The brand name is Sunosi, and it is like bupropion on steroids a little bit. It's a much more potent DNRI, and it's now being looked at for ADHD and depression. And it's not classified as a stimulant. It's Schedule 4, but it does have similar mechanisms of reuptake inhibition of dopamine and norepinephrine. And I'm just wondering, does that one make sense too? Perhaps it would be even a little better than bupropion.
You've got me intrigued. I'm going to have to look that up after this call.
All right, please do. It's called solriamfetol. The brand name is Sunosi. It's approved for excessive daytime sleepiness, either narcolepsy or sleep apnea. And a lot of these so-called WPAs, wakefulness-promoting agents, have other uses, as you can imagine. So, check that one out. Okay, we talked a little bit about using amphetamines, prescription amphetamines, to treat patients with stimulant use disorders. Amphetamine and methylphenidates have similarities but work slightly differently. Is there any use of methylphenidate in this regard?
There have been several trials, and there's been definitely some data of benefits with methylphenidate. I will say in practice, I've seen a lot more benefits with the more amphetamine type stimulants, more the dextroamphetamine, amphetamine salts. It's, the methylphenidate isn't kind of, I guess, potent enough for most people who are using methamphetamine. The doses are pretty high these days. It's kind of a similar thing with fentanyl. We struggle with our opioid agonists because they can't hold a candle to the amount of fentanyl on the street.
Yeah, it's interesting. And we also mentioned amphetamine is not only more potent at releasing dopamine, it also adds some serotonin, which methylphenidate doesn't do as much. It's interesting that they are slightly different in how they work. And I've always been fascinated when you talk to people who are, let's say, stimulant connoisseurs. Amphetamines have a much higher street value than methylphenidates. I used to say Adderall is a higher street value than Ritalin, for instance.
Right.
And that may be why. All right. You talked a little bit about something that I'm a big fan of, and I'll just roughly call it, and excuse me if I'm not using the right terminology, harm reduction. Many the FDA used to have as their bar complete abstinence to approve a treatment, but that's not always achievable, certainly in the short term. But they have loosened up a little more, and I think there is something to be said for harm reduction, for just getting the use down. Or is that a part of your strategy?
This approach is essential for addressing substance use, in particular stimulants. And you have to take a step back and look at what toxicities you're trying to address. With opioids, you can be 16 years old, use a fentanyl for the first time ever, and die. With stimulants, it's, we talk about the stimulant overdose crisis. It's really a terrible terminology. The deaths related to stimulants are mostly related to chronic cardiovascular disease that develops over decades of use and potentially other stressors. So stimulant toxicity is much more like alcohol toxicity. Most of the deaths are due to chronic disease. There's a handful that are true acute toxicity deaths, but the vast majority are chronic disease deaths. And so just like the FDA has done with alcohol by authorizing reduced use as a valid outcome, we have to think the same with stimulants. The legal status is more like opioids for stimulants, but the actual toxicity paradigm is much closer to alcohol, which means that we need to think about cumulative exposure and binge pattern use, just like we do for alcohol. So when I assess somebody's stimulant use, I go through their DSM-5 diagnosis, of course, but in the process of that, I also generate a gram year history of use, kind of like our pack year history for tobacco. And I assess if they sleep every night or if they go on runs for 1, 2, 3, 4, 5 days. Those are really critical to understand the depth of potential toxicity they have experienced and will in the future.
I see. So for our clinical audience, then, assessing not just what are they using, if you will, but the pattern of use sounds very important.
Yeah, just like we know that in my medical training, staying up for days on end shortened my lifespan because not sleeping is unhealthy. The same thing is true for people who are using stimulants. People who are staying up for 3, 4, 5 days in a row you're trimming off your life because you are accelerating that cardiovascular disease. That is what kills most of us in the end. So when I talk with patients, I tell people very explicitly, I have a 4-tier approach to addressing stimulants. I do my assessment. I do prevention, all the screening and vaccines and naloxone for overdose prevention that I should do. I do use reduction, and I do toxicity prevention and management. And that 4th tier, talking to people explicitly about the essentially inevitable toxicities of stimulants and any strategies that we can come up with, which are admittedly experimental, to reduce those or aggressively treat toxicities that exist. That discussion is kind of magical. What happens is patients hear that and they say, oh yeah, I want this to prevent the toxicity of my methamphetamine use. And then they come back a month later and say, Doc, you said that this, would help me prevent the toxicity of my meth use, but wouldn't reducing my meth use help even more? And didn't you say you had some medications that could help with that? And then they start on these medications and they actually start addressing their use. And it's been, for me, kind of revolutionary for those patients that really aren't interested in reducing use.
That, if I could just say, is a brilliant strategy, sort of making it their idea, if you will. So you sort of start a conversation. A lot of us clinicians feel like I have to fix it right now, but really when you're dealing with something chronic like this, you're kind of starting a conversation, aren't you? And eventually maybe it sinks in a little bit.
A longitudinal care is a lot more fun.
Yes, well said. Now, there is something called contingency management, and I'm not as up on that term. Can you explain what that is and how it works?
Sure. It's really our most well-studied intervention for stimulant use disorder that has the most evidence behind it. This is a program that involves following people and basically giving them rewards, whether it's prizes or cash rewards in escalating amounts for not using stimulants. Usually. So there are some tweaks and modifications that people make on the contingency management platform, but that's the basic idea. And it works. It works really well. The biggest barrier to it has been coverage. It's, I think we as a society are reluctant to pay people not to do bad things. And we have implemented a pilot of this through Medi-Cal funding in California, and it's been picked up by a couple other states. And we're seeing that, it really does work. It really helps people to, about a quarter of people will stop using, and a lot more will have use reductions.
I mean, I could imagine the criticism that we're bribing people. Well, I would think of it more like incentivization. That might be a better way to think about it. You mentioned earlier a little bit about digital, and I want to tell you, I just gave a lecture on prescription digital therapies. I've actually been very involved with some of them, particularly for ADHD, but there were a number developed specifically for substance use disorder. There was a company called Pear Therapeutics that developed Reset and Resetto. What are your thoughts about digital? And it's not only for treatment. I mean, there's lots of ways digital can be used here. What are your thoughts about that, and what is being used?
There are several digital companies that have developed apps and et cetera for remote management of substance use. I think there are some real benefits to it for certain populations. I have to be honest, the population that I work with loses their phones every week, and sustaining a digital intervention like this is not yet an effective option for most of the people that I work with.
Yeah, it makes sense. Part of it is it delivers a CBT. Part of it is to enhance adherence. Part of it is monitoring and things like that. But yeah, I see your point. It's definitely not for everybody.
Yeah, one of the monitoring things that I've started doing that's outside the box for my patients is I check a high sensitivity C-reactive protein prior to starting working on people's methamphetamine use. CRP has been associated with methamphetamine use, and the elevation is also associated with cardiovascular inflammation. And what I've seen, it's just a handful of cases so far, is as people report reduced use, which I can't prove because my urines are qualitative. You know, you might go from 2 grams a day to a half a gram twice a week, but your urine's still positive for methamphetamine. And so do I believe you? And if I send a CRP and your CRP went down, I can give you positive feedback and say, hey, you said you cut your use by 80% and your CRP is half what it was. That's less inflammation causing problems in your body. Keep up the good work.
Wow, that's a biomarker and it's very easy to implement. That's real easy to get a CRP.
That is one that's clinically available. Now, it has not been studied for this purpose. And there are many other things that influence CRP. For example, I would not try implementing it in somebody who has a comorbid autoimmune disorder that is escalating their CRP for other reasons. And I wouldn't, if the CRP went up, I wouldn't give it feedback that what they're doing isn't working or that they're being dishonest about their methamphetamine use, because I don't have the data to support that. So I'm using it more just as a biomarker to encourage people that they're doing the right thing when it suggests that they're doing the right thing.
Yes. Well, this is fascinating. Now, are you saying, is the C-reactive protein elevated before the methamphetamine use or more associated with or as a consequence of?
It's associated with methamphetamine use, and when people stop using their, we're seeing some reduction in CRP levels. Another agent for cocaine, I think it's endothelin-1 is a great biomarker, but that's not as clinically available, so a little trickier to use.
Yeah. C-reactive protein, every time I go to my doctor, they check it for cardiovascular risk and others. It's a non-specific marker of inflammation, like you said.
Exactly. So you're getting you're both getting the methamphetamine use and the cardiovascular risk that you're worried about. So as an internist, it fits really nicely in my workflow.
Yeah, well, when I did my internal medicine training, which I'm embarrassed to admit was over 30 years ago, we used to use the erythrocyte sedimentation rate, but this has clearly replaced that. Has a lot of advantages, if you will, but I find that absolutely fascinating. I bet a lot of our audience don't realize that stimulant abuse is associated with inflammation. We have been talking in our field a lot about the role of inflammation in mood and psychotic disorders, and there are a number of treatments being developed to try to address that, the system, the immune system, the inflammatory system. So I find this fascinating and potentially a target for treatment.
Most people think, and I used to frankly think as well, that the heart problems from stimulant use are because your blood pressure's up and your heart rate's fast and it's just mechanically causing heart problems. The reality is most of it is inflammatory mediated. Most of the heart damage is these inflammatory markers, which is also why I now offer a statin medication to patients who use stimulants.
Exactly. It's exactly what I was going to ask, because a lot of how statins work is not just cholesterol, it's anti-inflammation. So I think that makes perfect sense. And of course, managing blood pressure makes perfect sense as well.
Exactly. More aggressively than we do. Clinicians tend to undermanage existing cardiovascular disease in people who use stimulants, attributing it to the stimulant use and just saying stop using stimulants. But most people, frankly, aren't going to stop using stimulants. So more aggressively managing their high blood pressure. And, one thing I just have to throw out there is a long-standing myth that you can't give beta blocker medications to people who use stimulants. A myth that was, in fact, shown again on my favorite medical show, The Pit. The Pit is an outstanding medical show, really the the
Yes,
best emergency medical show that's ever been made, and really
the best since ER.
Shockingly accurate medicine.
Accurate. I agree with you. 100%
but
agree.
They, to my chagrin, reinforced the myth of unopposed alpha stimulation from beta blocker use in somebody using stimulants. It's a myth that has been disproven many times. And I've seen so many patients who have a clear indication for a beta blocker, their life would be prolonged, but they're put on amlodipine instead, which has no data in preventing the cardiovascular disease outcomes. So we need to buck up, use beta blockers. If somehow we're still scared, we can use carvedilol, which is a beta blocker that's also an alpha blocker. And, if somehow magically we just can't get over the myth, then we have alternatives. But amlodipine is not helping. We are cursing people with a myth.
Yes. Well, I was going to say, especially some of the newer beta blockers, which are, more appropriate. And then there was a myth in my training too, and largely based on, I guess, non-selective propranolol, that it would cause depression or exacerbate depression. And we know the newer ones are much less likely to do that as well. So thank you for bringing that up. It's extremely helpful. So we've talked a little bit about the evidence base. And so it sounds like right now the best evidence is those two medicines/combinations we've talked about. Are there other things on the horizon, other things being studied, other things that look promising to you?
One of the areas that people talk about a lot and think about a lot these days in addiction is the GLP-1 agents.
We have to address this. Yes, please. We have to address this.
Yeah, with semaglutide being, a key one, tirzepatide, and others that are out there.
There's many others in development, yeah.
We've all seen anecdotally really profound outcomes with these agents. Again, I wonder if there are subgroups that benefit more, and I wonder if there are phenotypes of addiction that might benefit more. The GLP agents really help a lot with craving. So maybe these addictive, these use disorders that are characterized heavily by craving are going to be more responsive to GLP agents.
Yes, very much. Well, as you know, there's a lot of preliminary evidence for three things: alcohol use, opioid use, and nicotine, smoking. As a matter of fact, there's a good friend of mine, Roger McIntyre in Toronto, who's also on our faculty at NEI, who is doing a lot of work with these for psychiatric indications like depression. And he taught me there are GLP-1 receptors in your brain, and they're in some interesting places, including prefrontal cortex. They may be pro-cognitive or at least neuroprotective, but also heavily in the ventral striatum, which is the motivation reward center. And this may not just be a peripheral effect from losing weight, and of course that decreases inflammation, but it may be an and rather than an or, and there's a central effect of modulating just like you modulate appetite. People tell me it decreases the food noise, which I guess is akin to craving. And they can maybe eat half the meal, and when they feel full, they stop instead of being compelled to eat the whole meal. And I guess there's an analogy here with substance use.
Absolutely. Yeah. I wonder in some cases if you need to pair this with some cognitive behavioral therapy strategies.
Yeah, I agree.
And I will say in other cases, I have had patients that have been started on a GLP agent for obesity and have ceased their alcohol use or their cocaine use with zero additional intervention. And those are absolutely profound moments. A patient who has a panic disorder, is on multiple psychiatric medications, and starts this GLP agent, drops from 8 bottles of wine a night to a glass of wine a week, and stops all their psychiatric medications and drops 40 pounds and feels fantastic. Still goes to the bar every night, but doesn't drink anymore.
My goodness, that is just remarkable. These drugs are sort of a new frontier, and there's a number of them, as you said, in development. As a matter of fact, I recently reviewed 6 protocols from Eli Lilly with a next-generation GLP-1. They're starting simultaneously, Philip. Check this out. Cognitive impairment in schizophrenia. We know that Novo Nordisk is doing a large series of Alzheimer's studies with semaglutide, so there's a lot of evidence of that. But also relapse prevention for depression, bipolar depression, alcohol, smoking, and opioid use disorder. So we may actually have FDA approvals for these things for such indications. It's just a remarkable development.
We always have to be cautious about these drugs that fix everything because we inevitably get burned. But they are exciting and they do have some real benefits and clearly a very important place in medicine going forward.
Well, I like what you said, that there may be subgroups who do especially well, like with our other medicines, and we just have a lot more to learn. I learned a long time ago, Philip, when something looks too good to be true, it usually is to some degree. So I think we have to keep our eye on that, and we'll have data. We'll have more data and evidence and so on. But the range of indications they have already is quite remarkable, and what they do, they are anti-inflammatory, they're pro-cognitive, antioxidative damage. It's just really remarkable. Again, modulating the motivation reward. I don't want to spend the whole show on that, but I just think we have to address it. Yeah.
To bring us back to stimulants for a moment, I can say if they are effective in reducing or stopping stimulant use, the weight loss benefits, given that everyone who stops stimulants puts on a lot of weight, the weight loss benefits of these agents could lead to a stable weight on cessation of stimulant use, which would be really fascinating.
I hadn't thought of that. That is really interesting. That makes perfect sense. I agree with you 100%. Let's talk with our last amount of time here. We have a lot of clinicians, we have a lot of lay people that listen to our podcasts, but for the clinicians, what would you recommend that they start doing differently tomorrow when assessing and or treating stimulant use?
Thank you for this question. I love it. So I would strongly encourage clinicians to openly tell patients that use stimulants that they have a 4-tier approach to addressing stimulant use: assessment, prevention, use reduction, and toxicity prevention and management. And on the assessment, to first ask people why they use stimulants. Stimulants have a functional role in life, like the tea that I've been drinking while we've been talking, that is hard to let go of, whether it's to stay alive on the street or drive a truck or complete a 30-hour medical shift. Stimulants have a functional role that most other drugs don't in life. So knowing why somebody uses is essential to addressing their use. And whether or not they have a use disorder, stimulant use carries toxicities. So I would still address it, even if they don't qualify for a use disorder.
Could I just put a pin in what you just said? This is something I've been a big fan of. And I mentioned this earlier. I try to understand how, I don't say, why are you using? They don't always know, but how does it work for you? What is it you're trying to do, maybe? How does it help? And a lot of times that can be a clue to co-occurring psychiatric disorders, as we said earlier, that they may be using them for some reason. But I like what you're saying. I hadn't thought about the other reasons people use, the other ways that they find it somewhat helpful, I guess.
We've also found that a lot of people use stimulants for pain self-management. And that sounds, like, it's like having a whiskey at night or whatever. But there's actually a neurological pathway, the cocaine-amphetamine receptor transcript system, that is effective in reducing neuropathic pain. So, and there's plenty of data from years ago, from anesthesiology data, showing that adding a smidge of a stimulant to a smidge of an opioid really magnifies the benefit you get in analgesia. So we know that stimulants actually are effective analgesic agents, and understanding that somebody's using it for that reason is just helpful in figuring out how you're going to address their use. I'm not saying we start prescribing methamphetamine for chronic pain.
No,
but
no,
it is
or opioids to
but
people who are methamphetamine users. Yes,
right. But it's important to know, and maybe that's a patient, frankly, who might have a lower threshold to use an amphetamine type stimulant for treating them. I don't know.
Well, no, that was an eye opener. That's an eye opener for me. Thank you. That's really helpful. Yeah. But go back to your 4 points. I'm sorry, I interrupted you.
The second stage is this aggressive preventive management. Screening for sexually transmitted infections, HIV, hepatitis C, tuberculosis, and doing it on an annual basis. That Hep C antibody that you set in 2016 doesn't count anymore. It's really old. You got to send it again. And really aggressive vaccinations. The number one reason somebody who uses drugs gets admitted to the hospital is pneumonia. So, getting that pneumonia vaccine in there, getting the HPV vaccine, which we can give up through age 45 and prevents multiple cancers. These are really, really important and can really prolong lives and improve the quality of life. Making sure everyone has naloxone. So that's kind of my prevention tier. And then the use reduction we've talked about. There's a couple of medications that are really low barrier, easy to try. And then the toxicity prevention, talking with a patient about the cardiovascular and neuropsychiatric toxicities of stimulant use, which include, from the cardiovascular side, heart failure, coronary artery disease, aortic dissections, valvular disorders, lots of different strokes. And on the neuropsychiatric side, it's the cognitive decline, the psychotic disorders, the Parkinson's disease. And I offer people a statin medication. I send a CK before I start a statin because some people who use stimulants have a baseline elevated CK. And I don't want to check it later and attribute it to a statin and then have to put the statin on their allergy list. So I want to know it's already elevated. And if I'm going to start a statin, I have a baseline.
Of course. And you have to get LFTs as well with statins, of course.
And then and I also am going to, I'm going to judge how hard I'm going to recommend a statin based on how much they've used, how long they've used, what other cardiac risk factors that they have. If they're 26 and they've used, once a week for 6 months, I'm not going to push a statin because statins aren't 100% benign. They're slightly diabetogenic. You've got the potential CK muscle issues that are uncommon, but they do happen. So they're not 100% of a benign intervention. But if somebody, is 40 years old and has been using methamphetamine for 15 years, even if they don't qualify on the cardiac risk score for a statin, they should, because we just don't include stimulants in any of our risk scores.
That's right. Well, and I was fascinated by that C-reactive protein. Have you seen C-reactive protein come down with statin use as well? A little bit?
It's it's interesting. Most of the patients that I've treated, they start taking the statin because I'm in an outpatient HIV clinic where I have an even lower bar for statin use. And so is the reduction in CRP their statin use or their reduced methamphetamine use? I'm not sure.
Right. Yeah, well, who cares? As long as it's getting better, I guess.
It's also, statins also show neuroprotective benefits. So they prevent the nerve cell death from stimulants in the brain. And they also, when you give, in animal models at least, if you give statins, they prevent the cognitive deficits from stimulants in mice. So we have some animal data for cognitive benefits. And you also have the data that statins can delay onset or prevent Parkinson's disease. So they seem to be a little bit dopamine neuron protective, which is fascinating and could block some of the stimulant toxicity to that system.
Well, thank you, Phillip. I was not aware of that. And now I'm imagining the gold standard treatment in the next few years is going to be a statin plus a GLP-1 agonist. So this is exciting, as you said. There's a lot going on here, and we certainly need more research. And I really hope that the clinicians in the audience and lay people in the audience who may be struggling with this themselves or have a loved one, I hope you've learned something here that's helpful to you. And Phillip, all I can say is I have learned a tremendous amount. I really appreciate your time. This has been a really enlightening conversation. And I want to thank you very much for joining us.
Thank you, Andy. It was a pleasure.
Thanks so much. Now, for more information about our educational offerings and our podcasts, please go to our website, which is neiglobal.com. Thank you so much.
Thank you for your participation in this CME NEI podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to print your certificate. This concludes the CME podcast presentation. For more information about NEI and our premier educational content, please visit neiglobal.com.